So hi guys, again I welcome everybody on this to this class. Here we'll be discussing the diploma paper, and this is paper number 1, which we'll be discussing. Very soon we'll be having diploma exams as well, the theory exams. I hope you people do know about the dates and all. And one of you can please just share the details of whatever recent information has come from the diploma and DNB official site. Okay. Let's start with the first question. There was a first question. There was a question that was asked on physiology of ovulation. Now, this is a question that has been repeated before as well. And physiology of ovulation, physiology of menstruation, they keep asking that, right? So initially, I've written down a couple of lines just to introduce the topic. Then, of course, we'll start with the follicular. Always you can start with simply the follicular phase, okay? So this is constructed in such a way in which you can write down an answer of 5 marks and even 8 marks, right? So follicular phase, it starts from day 1 to day 14. You know what it happens over here. It starts right from the first day of menstruation and ends with ovulation. This is a very important phase, right? And characterized by the development of ovarian follicles, not only the recruitment of the follicles, okay, one of which will mature, eventually get released as ovulation. Follicular growth is stimulated by the FSH. So the most important hormone happens to be FSH. This is an undergraduate level question. I mean, I don't even feel like discussing, but it's okay. Ovulation is the release of a mature egg. So you know what is ovulation? It's the releasing of the mature egg from the dominant ovarian follicle, and it is triggered by LH surge. Okay, that also is very important. Typically around day 14 of a standard 28-day cycle. Then you have a luteal phase. After ovulation, you have the luteal phase. What happens in this luteal phase? We have follicles, they transform into corpus luteum. The corpus luteum is formed, and then you have this corpus luteum, it secretes the progesterone. Okay, and what happens is that it prepares the endometrium for potential implantation. And if the fertilization does not occur, it finally, corpus luteum regresses and leads to a drop in the hormone levels, and there starts the process of menstruation, right? There's another way in which I can describe this process of ovulation. You have the hypothalamic pituitary ovarian axis. Okay, so I have this diagram for you here. All right, so this is what happens. So hypothalamus, it releases the GnRH. GnRH works on the pituitary and releases the FSH and LH hormones, which are the gonadotropins. And then you have they act on the ovaries, and finally they release the estradiol and progesterone hormone. Their negative feedback is going to stop the hypothalamus from releasing it further. But this FSH does what? It stimulates the follicular growth. This is very important. This is actually the gist of ovulation. And once the dominant follicle is produced, then you have the estradiol being produced in the bloodstream, and that triggers the LH surge. This is also equally important. Okay, estradiol is also equally important. Until once you have estradiol, the trigger will not be there for LH, and then ovulation might not take place. Okay, so there has to be some dominant follicles. Only then estradiol is going to be produced by the dominant follicle, and then will be an LH surge. So you can have a problem here, and you can also have a problem in final ovulation. Finally, right? And the residual follicle, they forms the corpus luteum, secretes progesterone, and that prepares endometrium for implantation. So you have a huge, this entire thing I have prepared for you, in such a way that you can answer this. You don't feel it's an incomplete diagrammatic representation only. You can write down properly, because when earlier I used to make it easy and simple for my students, they would still search the notes. Okay, so that is why I started preparing lengthier answers now. So control of ovulation involves the HPO axis, and here is the entire breakdown. What hypothalamus does, anterior pituitary gland, follicular development, what happens in recruitment of follicles. When you have a selection of the dominant follicle, then that releases the estradiol, that causes the LH surge. The same thing being repeated again and again and again. So if you have a lengthy answer, this is the way to go about it. And if you want to cut it short, this is the best way to write down. Okay, so the examiner will get a hint of what you know. Right? Like I always say, make, skeletal diagram first. Your answer should have a skeleton first, and then you input the points. So you will never ever have a dearth of time. Correct, guys? Then, of course, there are certain post-ovulatory changes, which is not asked in the question, but I've just mentioned it now. Then there was a second part. The second part was markers of ovarian reserve. Now, all the students that I have in the class, okay, doesn't matter. You have to just write down quickly in the chat box what all are the markers for ovarian reserve. Then I'll tell you what all do we take nowadays and which ones are obsolete. So whatever you can think of, start writing down in the chat box. Let's discuss. Okay, so that will be my interaction with my students. I always like to interact with all of you. So please start writing down what all do you know about the markers of ovarian reserve, and please feel free to answer. There are a lot of students who are there on the channel, but I don't know how many are there in the class. I think they join in between. Yes, so you have very good. The first two are the most important. The AMH and the anti-Mullerian hormone and the antral follicle count, very very important. And then FSH, some people say, but it's not considered very important nowadays. Very good. Ovarian volume, some people say that is all. I have included all of them because your answer is going to be looking. They will look forward to all these. Okay, but they might or minus, you can put it down. So first you write on AMH, you can also write on FSH, you'll write on antral follicle count, and then ovarian volume when not considered very important these days. Okay, so yes, absolutely right. I wanted all of you to take some part in the discussion. So AMH, yes, definitely currently considered one of the most reliable markers of ovarian reserve. Why? I'll tell you why. AMH is obviously produced by the granulosa cell. That is very important to be marked by the small antral follicles, which are indicated with the pool of resting follicles. So basically, the resting follicles, all of them, they produce the antral follicles. I mean to say, antral follicles, they're producing the anti-Mullerian hormone. These levels, they correlate with the number of antral follicles. So basically, you have the what do I call the small antral follicles? They are the ones only who are producing. So that is one reason. They are the ones who are producing the anti-Mullerian hormone, okay, not the dominant and the mature ones. So you have the measurement of AMH is correlating to how much antral follicles you have currently present. That's number one. And the second thing is that the levels also, they remain pretty stable throughout the menstrual cycle. Like why do I say that FSH should be done on day 2? Because it fluctuates. Even estradiol, it fluctuates. LH fluctuates. You have a surge somewhere and you have absolutely low level somewhere. But AMH is almost stable throughout the cycle. So it does not really matter when you've done it. That's a very, very important and very helpful factor. So there are two very important reasons for AMH to be the most bankable marker for ovarian reserve. One is it's a direct measure of the antral follicle reserve. One, and second, it's the stable levels. But yeah, there are certain limitations. It's not a perfect predictor. Okay, so age, genetic conditions, environmental factors, they do influence AMH, but overall, roughly, it is the best. FSH we have dropped these days. We don't take it much, but FSH nevertheless will always come, right? So FSH is a well-established marker of ovarian reserve. It's produced by pituitary gland, stimulates the growth of follicles in the ovary. Okay, and a woman with good ovarian reserves usually will have a lower level of FSH sufficient to stimulate the follicular development, and that is very important. So a patient who has a good ovarian reserve, you do not require a lot of stimulus for FSH, right? Or of FSH. FSH levels and interpretation is that you have typically measured on the second, third day, I just told you, right? Generally, FSH levels above 10, they tell you about diminished ovarian reserve, and above 20, they indicate poor ovarian function. Remember that it's good for Viva. It's important for if you're interested in one of those MCQ based papers in your need assessment. These are very important points. Above 10, they say diminished ovarian reserve, and above 20, they say it indicates a poor ovarian function. So yeah, it has its own. Now the limitation is that its values keep changing all throughout the cycle, especially for those patients who are having amenorrhea. It becomes very difficult for us to manage and measure and rely on FSH. And basically now FSH role has shifted to diagnosing the patients with menopause. So any patient, let's say she's a 38-year-old patient, and she's not had menses since the past, let's say 18 months. How will you call her having menopause? She's not going to agree with you. So you go ahead and do the FSH and do it twice with a 4 weeks gap, and then tell her that it's like you're having a problem, you have already achieved menopause, because now there are 2 tests which have confirmed that FSH is way high for your age, and probably you're having a menopause. This will be called as a premature ovarian insufficiency. So it's become mostly a marker for POI. Then, of course, antral follicle count is still very important. So basically, we try to measure, the small follicles. Small follicles, I mean, I'm talking somewhere between 2 to 10 mm follicles. Okay. So these antral follicles are directly proportional to the number of primordial follicles, and they are actually the pool of resting follicles. It's very, very important. But typically, an AFC of less than 5 to 7 is considered low. So we should know what is considered low and which is considered sufficient. So anything above 20 can be associated with conditions like PCOS. So you have to kind of stay somewhere in between. So it's 10 to 20 ke beech mein. Somewhere in between 10 to 20 is good enough. So yeah. Now AFC is operator dependent. Remember that everybody who's doing the transvaginal ultrasound will probably be the best person to give you antral follicle count measurement. But again, whether they are seeing 2 millimeters or 3 millimeters or 1 millimeter, then it becomes 10 millimeter or 11 millimeters. Then they say, no, this one is not actually antral follicle. You never know. So these are the important things that you have to see when you are measuring, and these are the important. So I said FSH, I said AMH, I said AFC, and then you have estradiol to a certain extent. Okay, elevated estradiol levels on day 3 indicate reduced ovarian reserve. Why? Because it suggests the follicles are producing more estrogen to compensate for fewer eggs, and they want an LH surge. The body needs an LH surge, so they're producing more and more of estrogen. Every time you have more of hormones in the body, that means that the trigger has to be so strong. The body is realizing that the hormone is not being produced, or there is not sufficient follicles, because of which the body is reacting in such a way. You have to understand and analyze the situation immediately. So that means elevated estradiol levels on day 3 indicate reduced ovarian. Why do they do that? Because follicles are producing more estrogen to compensate for fewer eggs. You have to have a higher spike, but the eggs are low. So if you had many eggs, they would have probably gotten together and produced a stable amount of estradiol, and it would have led to LH surge. But only, very few follicles will produce higher level of estradiol on day 3, okay? Not just right before the LH surge, not on day 10 or something. So again, estradiol again is not used because it fluctuates throughout the menstrual cycle. Do you see this line? It fluctuates throughout the menstrual cycle, so that is why it is an interpretation and challenging, again, like I said. So we want something more stable like AFC or AMH. In the same way, inhibin, again, granulosa cells produced by the granulosa cells in the developing follicles. Again, in the developing follicles, so it inhibits the FSH secretion and it reflects number of small healthy follicles in the ovaries. Inhibin levels are highest in the early follicular phase and they decline as the ovarian reserve diminishes. So as high as those follicles you will have a considerable level of inhibin, again marker for the quantity of follicles, and lower levels they suggest diminished ovarian reserve. Okay. Now, inhibin B can also fluctuate significantly throughout the menstrual cycle. So again, we have a problem there, which is why again it's not considered. Ovarian volume nowadays is not considered another marker, but yes, you will always write these things down and you will write how to interpret. That's very important. 2 lines. Why ovarian volume is? Why are we even measuring it? What does it tell you? Okay, like I just told you AMH. Why is it important? I just told you why is FSH important. I told you antral follicle count is important. Why is ovarian volume important? Because that tells you another marker. Ovarian volume tends to decrease as the woman age, and the ovarian reserve diminishes. Women with smaller ovarian volumes typically have fewer antral follicles, right? But again, this is operator dependent, requiring skill, ultrasonography, and the limit for which you have to kind of move around when you're talking about ovarian volume is a few millimeters. So I don't think it's a very, very important parameter. Even millimeters or centimeters, like for example, you say 3 to 4 centimeters ovary, 1 to 2 centimeters ovary. How much difference does that make? Is it easy for anybody to say, no, it's not 2 centimeters, it's 3 centimeters? It's hardly a centimeter, you understand? So the difference is there. Now, why am I saying is very important is because there is a significant observer difference. Just give me 2 minutes, guys.